Today we're going to be taking a look at the water deprivation test, which involves measuring urine osmolality levels to confirm a diagnosis of diabetes insipidus. Before looking at the test in more detail, it's important to understand how anti-diuretic hormone, or ADH, functions within the body. So if you remember, ADH is produced by the hypothalamus and is then stored in the posterior pituitary gland before being released to activate the kidneys, and more specifically, the collecting ducts of the kidneys. We can look at this final stage in more detail, and what happens is that ADH binds its receptors on the collecting ducts, and this triggers aquaporin II channels to fuse with the cell surface membrane, thereby allowing water to enter the collecting ducts via these aquaporin II channels. Once inside, these water molecules can be reabsorbed back into the blood via channels on the basolateral side of the membrane. And you can see that the overall effect of this process is to increase water reabsorption and maintain blood pressure. What happens in diabetes insipidus is that there's a decrease in the production of ADH or a decrease in the response to ADH, and it can broadly be divided into two main categories: cranial diabetes insipidus and nephrogenic diabetes insipidus. In terms of the cranial causes, what normally happens is that there's insufficient ADH being produced as a result of a problem to the hypothalamus, and this can be due to brain tumors, head injuries, or infections. During this process, with less ADH being produced, the aquaporin II channels cannot fuse with the cell surface membrane, and therefore water reabsorption decreases back into the blood. In terms of nephrogenic diabetes insipidus, here there's ADH insensitivity, so ADH is still being produced, but the cells of the nephrons aren't responding to it properly. And this can occur due to congenital effects, so for example aquaporin II channel mutations, or acquired abnormalities, such as lithium, electrolyte changes, or infections. In this case, ADH may still be produced, but for example in the case of congenital abnormalities, these are impaired aquaporins, so water reabsorption back into the blood is still decreased. The gold standard test for the diagnosis of diabetes insipidus involves two main phases. The first phase involves water deprivation, where the patient's fluid restricted, and then the starting urine osmolality is measured after 8 hours. And just as a quick recap, urine osmolality refers to the concentration of ions within the urine. So for example, in this first diagram, you can see that there's many water molecules present, and this would be deemed a low urine osmolality, compared with the second diagram, where there are more ions present, and this would be deemed a high urine osmolality. The second phase of the test involves administering desmopressin to the patient, and then the ending urine osmolality is measured after 8 hours. And just to summarize this, the first phase of the test involves determining if a diabetes insipidus diagnosis is present, and the second phase is trying to find the cause behind the diabetes insipidus, in other words, whether there's a cranial cause or a nephrogenic cause. Let's start by taking a look at the first phase of the test, which involves measuring urine osmolality after fluid restriction. In normal individuals, what should happen is that after water deprivation, the levels of water in the blood should decrease over time. And as a result, the body tries to compensate by reabsorbing more water back into the blood from the filtrate. And this occurs via ADH mechanisms. As you can see from the diagram, there's now less water in the filtrate, and therefore less water in the urine, so the urine osmolality increases in a normal test result. And this occurs because the body is trying to conserve more water. Comparing this with diabetes insipidus, again, the levels of water should decrease after water deprivation, but in this case, water is not reabsorbed back into the blood from the filtrate due to problems with ADH, and the urine osmolality therefore remains low at less than 400 milliosmoles per kilogram. Based on this, if a patient has a low urine osmolality after water deprivation, we can confirm a diagnosis of diabetes insipidus, and we should move on to desmopressin testing to find the cause behind it. The second phase of the test involves administering desmopressin to determine whether there's a cranial cause or a nephrogenic cause behind the diabetes insipidus. In cranial diabetes insipidus, the main issue is with a lack of ADH, so when we administer desmopressin to these patients, it acts as an ADH analog, thereby allowing the aquaporin II channels to fuse with the cell surface membrane and allowing water to re-enter the collecting ducts and therefore the blood. As you can see from the diagram, there's now less water in the filtrate, and therefore the urine osmolality returns to high or normal levels, as the problem has been rectified by administering the ADH analog. Comparing this with nephrogenic diabetes insipidus, in this case, there's already enough ADH being produced, and the problem instead lies with an impaired aquaporin or problems with the collecting ducts themselves. Therefore, when we administer desmopressin to these patients, it has no effect on increasing water reabsorption back into the blood, and the urine osmolality remains low as a result. In other words, we can compare the urine osmolality levels after the desmopressin stimulation test. If they remain low, we can confirm a nephrogenic cause, and if they return to high or normal levels, we can confirm a cranial diabetes insipidus. And here we have a quick summary flowchart outlining the key results from these tests. I hope you found this video helpful, and I'll see you in the next one.